دلوقتي هنبدأ الجلسة الثانية في هول A. الجلسة الثانية Health Burden of Prediabetes, Diabetes and Obesity. First speaker, Professor Dr. Inass Shaltout, Professor of Internal Medicine, Diabetes and Endocrine, Cairo University, and is the President of Arabic Association of Study of Diabetes. The lecture is titled Anti-obesity Medication versus Bariatric Surgery. Should we apply guidelines?
Bismillah ar-Rahman ar-Rahim. Thank you very much for the introduction. I'm going to talk about a hot topic, anti-obesity medications versus metabolic surgery. Should we apply the guidelines or not? This is obesity prevalence worldwide. Obesity is rapidly unfolding health crisis. According to WHO, we are having 800 million persons living with obesity. This is a huge problem, and by 2050, there is going to be 1.5 billion persons living with obesity. This is our region. Sorry, this is the slide with the 800 person living with obesity. And in our region, we have obesity prevalence exceeding 30%. This is a huge problem in our region. Also in the USA, you can find obesity prevalence above 30 is highly present. The magnitude of the problem, obesity, is linked to the development of multiple diseases, frailty, and diminished quality of life. And research shows that weight loss interventions, including anti-obesity medications and lifestyle modification, they reduce the risk of obesity-related comorbidities. GLP-1 receptor agonist was the first powerful, potent anti-obesity medication recognized and approved by FDA, and it has been shown to be effective in promoting weight loss. In preclinical trials and also in clinical trials, it was first introduced as an anti-diabetic medication, then later on it is approved as anti-obesity medication. There is combined central and peripheral actions of GLP-1 receptor agonist, promoting satiety, decreasing hunger, and ultimately they reduce weight. In scale trial, using liraglutide 3 milligram led to weight reduction of mean of 6%, and in other trials, the weight loss was between 5 and 10%, and in early responders, there was 11% weight reduction with liraglutide 3 milligram. In Sermon trial is about tirzepatide. Tirzepatide is a combined GLP-1 receptor agonist with GIP, and it led to 21% weight reduction. It appears to be the most powerful available anti-obesity and also anti-diabetic medication, and it can lead to weight loss up to 26%. It is among the present anti-obesity medications, it's the most powerful, but soon in the future, in the near future, we're going to have more GLP-1, GIP combinations. They are going to be available soon, and we have many products, maybe with greater efficacy. These are other available FDA anti-obesity medications. We have orlistat, we all know orlistat. We have phentermine, topiramate, and naltrexone bupropion. Orlistat can lead to weight loss of 9.6 versus 5.6 in placebo group. Then it led to about 4% weight reduction, more than the placebo group, with some side effects on the liver. The phentermine topiramate can lead to 7 to 10% weight loss. The side effects include tachycardia, hypertension. There is a safety concern in those with suicidal thoughts. So we should have a good history from our patients. Also contraindicated in glaucoma, metabolic acidosis, coronary artery disease, hyperthyroidism, and it's not recommended for long-term use. So take care of this medication not to be used more than 12 weeks maximum. Naltrexone, bupropion, can lead to 5% weight loss compared to 1.8% in placebo group. And side effects include agitation, mood change, tachycardia, hypertension, possible withdrawal symptoms, seizures, and it is contraindicated in hypertension, hyperthyroidism, epilepsy, and history of suicidal thoughts. In case of less than 10% weight reduction in the first 12 weeks, then these patients are not good responders. We should not continue these medications, and it's not recommended for patients below the age of 18 or above the age of 65 because of some CNS possible side effects. Coming in the pipelines, we have rotrutirotide. It is a GLP-1, GIP, and glucagon receptor. It is considered a triagonist. And the glucagon receptor agonist, the action, it leads to enhancing lipolysis, inhibition of lipogenesis, increase energy expenditure, increase thermogenesis, and it has an anoretic effect. Again, those are coming in the pipelines, still in the phase 3 trial. It led to 19% weight loss, survodutide. And also we have orforglipron. It is a small molecule of oral GLP-1 receptor agonist. It is still in phase 2 trial. Led to 14.7% weight reduction. Then we are having in the pipelines very good medications and expecting to have them soon. The Canadian obesity guidelines, these are the Canadian obesity guidelines. Who is eligible for bariatric surgery? When you face a patient, you need to determine whether this patient is going to have successful weight reduction with anti-obesity medication, or you should refer this patient for bariatric surgery. Canadian guidelines said that patients with severe obesity, with BMI more than 40, or more than 35 with severe comorbid conditions may be considered for bariatric surgery when behavioral intervention is inadequate to achieve healthy weight loss. Then we should start with behavior change, lifestyle modification, diet, and exercise. This is the effectiveness of bariatric surgery. Most of bariatric surgery led to weight reduction between 10% and 26%. But after 10 years, those bariatric surgery bypass operation, the percentage of weight loss decreased from 26% to 21%. Then some of the weight reduction is not maintained. And this is the table for each type of bariatric surgery and the effect after 4 years of the operation and after 10 years of the operation. This is the effect of anti-obesity medication versus bariatric surgery on the quality of life. Most anti-obesity medication led to better quality of life, while the anti-obesity led to a better quality of life, while the bariatric surgery led in the beginning to better quality of life. But after 5 to 6 years of the bariatric surgery, patients started to suffer of psychological disorders. They are not expecting what is the effect of the operation, because the effect of operation, you're going to have some skin redundancy, some disfigurement, sometimes weight regain, and those patients will suffer, and they found that health-related quality of life after bariatric surgery improve in the first 1 to 2 years, then deteriorate in the following 5 to 6 years. Coming back to comparison between anti-obesity medication versus metabolic surgery, we knew that anti-obesity medications can lead to up to 26% weight reduction, and the bariatric surgery can lead to 21 to 26% weight reduction. But we have major complications with bariatric surgery, whether during the operation or early post-bariatric surgery complications in the first months, or lifelong complications and supplement use and nutritional therapy. And the patient is not going to have a result with the end of the bariatric surgery. No, it is a lifelong condition. So what to choose? We're going to have soon some guidelines, and we're going to share these guidelines with you. It took 2 years from ASD to do a guideline. I hope it's going to be beneficial, and we're going to discuss it with all of you, whether to choose bariatric surgery or to give anti-obesity medications to our obese patients. And before doing any bariatric surgery, there should be a multidisciplinary team. There should be a psychological counseling from the gastroenterologist, counseling of the diabetologist or endocrinologist or internal medicine specialist, together with the surgeon. And the patient should be given a trial for diet and exercise months before the operation. And also, if the anti-obesity medications are going to produce considerable weight loss, maybe this will change the decision for the bariatric surgery. Clinically significant side effects were seen in those doing bariatric surgery versus those doing lifestyle modification. This is a well-known outcome. Again, this is the National Institute of Health guidelines. They said the same, either above 40 BMI or 35 with high-risk comorbid conditions, such as severe diabetes, life-threatening cardiopulmonary issue, or obesity-related physical problems like those who can't walk, became bedridden due to obesity. Then maybe you need to do a radical weight loss. And also we have other beneficial effects of GLP-1 receptor agonists. They are not just anti-obesity medications. They have other benefits far from being just anti-obesity medications. They lead to cardiovascular risk reduction, renal risk reduction, stroke risk reduction, and they have beneficial effect on NASH and possible associated anti-inflammatory effect on the perivascular adipose tissue. And also they reduce the incidence of prediabetes and diabetes, and all other beneficial actions are beyond the anti-obesity effect. So they have other mechanisms. Maybe some of them are clear and some of them are still unknown. They have beneficial effect more than just being anti-obesity medications. In conclusion, in view of other beneficial effects of GLP-1 receptor agonists and also GLP-GIP anti-obesity medication, they can overweigh the use of metabolic surgery, especially with known complications of metabolic surgery, which is an invasive surgery. On the other hand, bariatric surgery and anti-obesity medications can be complementary to each other. We can use anti-obesity medication before bariatric surgery to reduce the burden of obesity, and also we can use the anti-obesity medication after bariatric surgery if there is no considerable weight loss. Then they can be complementary to each other. Thank you very much.
Thank you, Professor Dr. Inass. Professor Dr. Inass presented her lecture, and as she said, is that with the new drugs and the drugs in the pipeline, the use of bariatric surgery will be decreased, and I think the drugs use will be increased, and this is good to prevent complications and to not expose patients to morbidity and mortality. Thank you, Professor Inass.
My pleasure.
دكتورة إيناس معلش I have a comment. طبعا أنا متفق مع حضرتك جدا جدا جدا، ومتهيألي الكلام ده واضح للناس جامد، إنه عيان اللي بيعمل بارياتريك سيرجري هو يبص على شكل بس جملة حضرتك دايما إنه المريض الأوبيستي بيتحول من مريض أوبيستي إلى مريض آخر بعد البارياتريك سيرجري، ودي متفق معاكم فيها جدا جدا جدا. وبقول لحضرتك إنه العيانين لازم يراجعوا الجايد لاينز، ولازم جايد لاينز تتحط فعليا عشان كنترول السيرجري، لانه البارياتريك سيرجري مش عمليه سهله ولا بسيطه، ده بتحول العيان الى another patient with different category.
شكرا دكتوره ايناس،
شكرا لحضرتك،
المحاضره الجميله، وانا طبعا متفق مع حضرتك ومع دكتور هاني. هي الايم ان احنا تريديوس اوبيزيتي، وطبعا ده اكيد باقل الخسائر الممكنه او باقل الكومبليكيشنز الممكنه، ايذر دراجز، ومفيش داعي ان احنا تو جو تو انفيسيف بروسيدرز دلوقتي. يمكن كان البارياتريك سيرجري كان اوبشن موجود قبل كده علشان ماني افيلابل دراجز، او دراجز كان ليها سايد افكتس كتير، لكن دلوقتي احنا وي هاف ماني دراجز، والايم مينلي يعني تو ريديوس اوبيزيتي ايفن على كل الكومبليكيشنز، مش الطريقه اللي احنا بنريديوس بيها الاوبيزيتي. شكرا جزيلا لحضرتك.
شكرا لحضرتك، ميرسي. في سؤال
اتفضل.
هل هو ممكن يتاخد في البري دايابيتيك اوبيس بيشنت في البي سي او مثلا؟ هل هو والميني انسان حاجه المينيمم ايج تو جيف ات؟
ان هو يتاخد في البري دايابيتس طبعا ده مهم جدا، لان في ستاديز على الليراجلوتايد قللت البري دايابيتس افتر 3 years 80%، يعني حولتهم الى نون دايابيتك، فطبعا هو ممكن يستخدم في البري دايابيتس، هذا مؤكد. السؤال الثاني للبوليسيستيك اوفري، ايوه هو بيستخدم في البوليسيستيك اوفري، بيدي نتائج هايله، ويمكن دلوقتي بقى الكلام في مؤتمرات الجينيكولوجي على الجي ال بي 1 ريسبتور اجونست بالذات، الليراجلوتايد از ترايد وابروفد. بالنسبه للايدج، بالنسبه للليراجلوتايد من اول سنه 12، بالنسبه للسيما من اول سنه 12، بالنسبه للجي ال بي جي اي بي من اول سنه 18. ده الاف دي اي ابروفل.
Another question.
اتفضل حضرتك.
اهلا دكتور حسين.
problem in Egypt, not only for diabetes but also for other diseases like cardiovascular and pulmonary diseases. So I think if it is possible to make a retrospective evaluation for patients who went under anti-obesity drugs and the patient who did bariatric surgery, say for example in 1 year, and to follow up who got benefit and who did not get benefit. We see the complications who are get a great benefit from using either anti-diabetic or bariatric surgery, so we can get conclusion in Egypt for multi-center studies, and we can get final conclusion who can benefit from anti-obesity drugs and who can benefit from bariatric surgery. I think if we can did this, I think we can get a final impression about the problem in Egypt.
I agree with your opinion, Dr. Hussein. I tried to say this issue to Novo Nordisk to sponsor a post-marketing study or survey about the effect of their products. They don't have a plan for that, but really the effects are obvious in our practice, and I have patients, they lost considerable weight loss, even more than the figures in the studies. It's needed, yes, to do a comparison, and we did a good job. Maybe will be announced soon, our job comparing both of them. For bariatric surgery, it needs long-term, more than 1 year to see the late post-operative complications, because it's a lifelong complication.
شكرا دكتوره ايناس. حضرتك next speaker.
دكتور علاء معلش.
دكتور علاء.
دكتور علاء حبيب.
طب اتفضل دكتور
اتفضل
علاء.
يا بيه.
Dr. Inass, thank you for your elegant presentation. With all my respect, but still the cost of these drugs is a major barrier.
Yes, sure. But there is a cost for bariatric surgery also, lifelong cost.
أيوة بس لازم يبقى في جهود حثيثة من الكومبانيز إنها تريديوس الكوست. تريديوس الكوست. لأن أنا عشان أتشيف التارجت اللي هو 25% ده I should continue with these drugs for at least 6 or more months. والحاجة التانية برضو اللي عايز أسأل عليها what about if I stop the drug? The recurrence of the gain of weight.
هقول لحضرتك الحقيقة the fact. You should let your patient do lifestyle modification hand in hand with the anti-obesity medication to get a good result, and also for the patient to be able to stop the medication. But at least you should use it for 6 months, not less than 6 months. And during this month, the patient should try to modify his lifestyle, his exercise, try to change the quality of food. He should change his whole lifestyle to be able to stop the medications without weight gain to the zero effect. Okay?
شكرا دكتوره ايناس.